I'd like to welcome you to this edition of the award-winning PRS Journal Club podcast with your hosts, Drs. Francesco Egro, Nicole Phillips, and Ira Savetsky. Enjoy.
Hello all, and welcome back to another edition of the PRS Monthly Journal Club podcast for July 2018. I'm Nicole Phillips, Resident Ambassador from the Harvard Plastic Surgery Program, and I am joined as always by my co-resident ambassadors, Francesco Egro from the University of Pittsburgh and Ira Savetsky from NYU. This month, we are incredibly lucky to have Dr. William Hoffman as our guest moderator. Dr. Hoffman is Professor in Chief of Plastic Surgery and Vice Chair of the Department of Surgery at the University of California, San Francisco. Dr. Hoffman, thank you so much for joining us today.
Thank you for having me.
Before we begin, just a quick reminder to our listeners that this article, along with every selected PRS Journal Club article, is available for free online. You can find them on the PRS website, along with the article and video pairings selected to further enhance these discussions. The article we will be discussing next is entitled, The Impact of Once versus Twice Daily Enoxaparin Prophylaxis on Risk for Venous Thromboembolism and Clinically Relevant Bleeding. This article is a follow-up study out of the University of Utah and Stanford groups, with Dr. Christopher Pannucci as the first author. This group has really focused on the important question of the appropriate prophylactic regimen against venous thromboembolism, which, as we all know, is a leading cause of morbidity and mortality among plastic surgery patients. Outcomes of VTE events can be devastating, and the leaders of our plastic surgery societies have declared this topic worthy of significant attention and funding. The study being discussed today was in fact funded by the Plastic Surgery Foundation, as well as the Agency for Healthcare and Research Quality. So the central question of this study is the appropriate dosage and timing of chemoprophylaxis against venous thromboembolism within the plastic surgery population. The authors have previously presented two studies, which are compared head-to-head here, and the outcomes of these studies are presented as the basis for future research. In the first study, conducted between March 2015 and March 2016, 94 post-op plastic surgery patients were treated with enoxaparin 40 milligrams once daily for VTE prophylaxis. In the second study, conducted the following year, 118 postoperative plastic surgery patients were treated with enoxaparin 40 milligrams twice daily for VTE prophylaxis. Although previous large, multi-center studies have shown a significant decrease in VTE events with the administration of once-daily enoxaparin 40 milligrams, the rate of venous thromboembolism events did not drop to zero. In fact, there was still a 4.5% breakthrough rate of VTE events among high-risk patients, defined as those with Caprini scores greater than 8. These findings were upheld in the first arm of the study, and so the authors really wanted to find an objective means of measuring therapeutic effectiveness. They examined anti-factor Xa levels as a test for blood thinness, and found that over 50% of patients had an inadequate anti-factor Xa level while on the once-daily dosing of Lovenox. Significantly, these were also the patients who were found to be at high risk for VTE events. In the subsequent study with patients receiving twice-daily doses of enoxaparin 40 milligrams, less than 10% were found to have inadequate levels of anti-factor Xa. However, there was evidence that some of these patients were over-anticoagulated on this regimen. So when comparing outcomes between groups, there was a significant decrease in VTE events among the twice-daily dosing cohort, 0 events at 90 days compared with 5 events at 90 days in the once-daily dosing cohort. But there was also a statistically insignificant but clinically relevant increase in postoperative bleeding events, 8 versus 3. The authors propose that the results of these studies, when taken together, suggest that there may not be an ideal standardized chemoprophylaxis regimen for all patients. Rather, a weight-based dosing strategy may be more appropriate to minimize risk for both inadequate and over-anticoagulation. They suggest a dose of 0.4 to 0.5 mg per kg twice daily as a potentially optimum regimen, and point towards this as an area for ongoing research and study. So I'd like to open up our discussion to the rest of the crew here. One of the notable aspects of the study design, in my opinion, was the lack of consensus regarding how long to continue chemoprophylaxis following discharge. I think this is an important question. It's certainly one that's been closely examined among the staff here in Boston. Dr. Hoffman, I was wondering, what is your post-discharge routine with regards to anticoagulation, and how do you think we should monitor these patients in the outpatient setting?
Excellent question. I'm not sure we have a standard approach. In patients that don't have a history and are up walking by the time they go home, we do not send them home on enoxaparin, although we may send them home on aspirin or something oral. It's hard to know what the end point is, even though they're talking about 90-day events. I think most of the events occur in the first few days. PEs may occur a little later, but the clot in the legs probably occurs early. even during induction. A lot of people feel that's like the most important part of the procedure. So I don't think we have a standardized approach. And in terms of my personal practice, I do almost only facial stuff, and 2/3 of my practice is kids. So I haven't seen a thrombotic event in a long time. We honestly haven't had very many that have been reported through our QI process, because these are pretty high numbers that they're saying here, where they're talking about 5 or 6% thrombosis events. And in fact, when they're talking about it, they're talking about symptomatic events, where in fact we know that at least half of clots in the legs at least are silent. So the number is probably higher than what they actually are measuring.
I think Dr. Hoffman, to that point, if you don't mind me jumping in, I mean, it's very hard to know exactly what cases they're talking about, because are we comparing cosmetic cases to microsurgical cases? We might be comparing apples to oranges.
They have a table that looked at risk factors, and actually one of the things I noticed was that surgery greater than 45 minutes was significantly higher in the twice daily group compared to the once daily group. And so if anything, the bias was towards more events in the twice daily group, and in fact they had 0. So, but they don't actually tell you what kind of surgery it was. You're right.
Yeah, exactly. And do you feel that because of this, should the interpretation of these results be taken with a pinch of salt, given that, as you said, we don't know what procedures were included in these trials?
I think absolutely, and that would be helpful information for sure. They state that they were comparable groups, but they didn't really in the discussion, I think, but somewhere in the article they said that they were comparable groups, but I think they were just taking all comers that had higher Caprini scores. Since they were kind of randomly selected, I think it probably is comparable, but it would be helpful to have that information in the paper.
Absolutely, absolutely. Ira, what did you think about the paper?
I enjoyed this paper. I think overall it was pretty well designed comparing the two prospective clinical trials, but I certainly agree it would be nice to know what type of surgeries the patients were undergoing. Nonetheless, I think the evidence is compelling, and thromboembolism and pulmonary embolism, certainly one of the most dreaded fears, especially, we're talking about cosmetic surgery, and typically when we think of this, or when I think of it, I'm thinking, patients undergo abdominoplasty and they're not moving around, they're not walking, but certainly weighing the risk-benefit in each patient is critical. Dr. Hoffman, I want to hear your thoughts about sort of the increasing use of Exparel or liposomal bupivacaine. It's being used more and more in TAP blocks. We've been using it in our abdominoplasty patients more and more, and I think it's somewhat of a game changer that these patients are really up and walking and ambulating more. I'm curious your thoughts about whether or not this will potentially have an impact of maybe lowering venous thromboembolism and potentially pulmonary embolism.
I would think it would help. Certainly, we know that walking and moving around, or conversely not moving around, is a high risk factor for VTEs. And I would think that the sooner they're walking, the better. I was actually thinking when we were talking about abdominoplasties that I miss the days of the real surgical nurses, because they knew that they had to get patients out of bed. And now the nurses, they're much nicer now, maybe, but they feel bad for the patients. They don't want to hurt them getting out of bed. And a lot of times you have to encourage everyone. You have to encourage everyone in some way that the patients have to get out of bed, and that it's the nurse's job to help them do that. My wife just had her knee replaced a couple of days ago, and they had her out of bed that afternoon. Because in orthopedics, especially with knees and hips, they have a high rate of thromboembolic events, and they know how important it is. So they're kicking people's butts like right away, and I think that's critical to trying to prevent these events also.
Yeah, I think it is interesting. Yeah, the orthopedic hospitals, a lot of things that orthopedic surgeons do in sort of their management, there's a lot to learn. I think a lot of it, they work so closely with physical therapists that really get them going quickly. For us, it's pretty easy at Bellevue. We don't rely on the nurses. We sort of beat on the interns to get these patients out of bed post-op day 0. But yeah, certainly it would be nice if there was more attention from nursing and really getting them going quickly. Nikki, any additional thoughts that you may have?
This has been a great discussion. I think it's pointing to some of the challenges of this question are really, the plastic surgery patient population is such a varied patient population. I mean, there's no cookie cutter plastic surgery patient. And so I think this is a really important question. I think the authors are clearly doing very good work bringing our attention to it, but I think we're going to need to continue developing algorithms and guidelines that are very specific to each different type of surgery, ambulatory surgery, and different risk factors associated with, the patients and with the surgeries themselves. With that, I think we'll probably wrap up this discussion. I want to thank everyone for a really great conversation. Before we sign off, just a brief reminder to our listeners, please be sure to check out the other 2 July 2018 PRS Journal Club podcasts. And if you like what you hear, share us with your colleagues and rate us in the Apple iTunes store. If you haven't already, go ahead and like the PRS Facebook page, and please join us for our monthly Facebook Journal Club, where you can interact with each month's featured authors in real time. And thank you again, Dr. Hoffman, for joining us today.
Thank you.